and have a number of people on, so we'll start this morning, and I know more people will join. So good morning, everyone. Welcome to our first research-focused grand rounds of the academic year. I will begin with a land acknowledgement before I introduce our speakers. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. This morning, we're going to hear from a couple of speakers related to the CALM study, which is a really important mental health research study that has a number of sites across Canada, including at CHEO, and you will hear from Drs. Gary Goldfield and Nicole Racine, who are leading this effort, as well as Anna Maria Gennara, who is a research assistant working on the CALM study. I think it's quite fitting this morning that we're having a talk around mental health. Today is September 11th. It's been 23 years since the Twin Towers disaster in September 11th of 2001. And even though that seems like a very long time ago, there may be folks on this call that weren't even alive at the time that happened. But I think those of us that were around then remember it like it was yesterday, and we know that the mental health impacts of that tragedy continue to reverberate today. So this morning's speakers are Dr. Nicole Racine. Nicole is a clinical psychologist and assistant professor in the School of Psychology at the University of Ottawa. She's a scientist at the CHEO Research Institute and holds the CHEO Research Chair in Child and Youth Mental Health. And her research examines the impact of early adversity in early childhood and identifies prevention and intervention approaches that promote resilience. Dr. Gary Goldfield is a senior scientist at the CHEO-RI, professor of psychology, a longtime member of the HALO group, and his research has focused on childhood obesity, screen time, and other external factors that impact mental health of children and youth. And Anna Maria Gennara is a research assistant with the CALM study. She has a master's degree in psychology from Carleton and has led the kickoff and startup of the CALM study at CHEO. She has expertise in data science and wearable technology. So a great trio of speakers this morning, and I will turn it over to you, Gary, to lead the discussion.
Great. Thanks a lot, Jason. So Nicole and Anna Maria and the whole research team were very excited to present our CALM study. So CALM stands for Cohort Network for Adolescents and Youth with Multiple Mental Health Conditions, a master observational trial. And so before we describe the study, I want to note that Dr. Kathy Pager played a pivotal role in securing funding from Ontario Brain Institute for this multi-center study that is run out of Sick Kids in partnership with CAMH. CHEO is a major site, one of 6. 5 are in Ontario, 1 site is in Calgary. I'm not sure if Kathy's on the call, but she's played an active role, not only in securing funding, but in the development of the protocol. CHEO is going to take a PCYMH perspective on this. So we're very excited. Our add-ons to a very large study are quite unique, and we think we're going to make very important scientific contributions. And before I hand it off to Nicole, I would like to say that this is the largest study, I believe, ever done in mental health patients in Canada. We're measuring everything from the microbiome to neuroimaging. We're really trying to get a better understanding of biomarkers and psychosocial familiar predictors and how they all interact to predict not only development of mental health severity and comorbidities, but recovery from treatment and which types of people recover from which treatments and why. So without further ado on that broad overview, I will hand it off to Nicole.
We've the slides seem to have disappeared. They were up a moment ago. There we are. And do you want to just put it in in slide mode or full screen? Perfect.
Yeah, you see them? Okay, great. Thank you, Gary, and thanks for the invitation to talk about the COM study. I think, as Gary mentioned, we're incredibly excited about the fact that CHEO is an important player and site for this study. And what we're really hoping to do today is describe the study to you, where it came from, how it came to be, the important components, what we'll be measuring, how it will launch. And the major goal is that actually this is something we're all going to do together, because it's not just the individuals who are, who've been appointed to lead the study, but rather this is a study that's happening at CHEO, something I think we should be incredibly proud of. And bringing and welcoming youth and families into the study will be something that's done collectively. And so our team will certainly be providing support for that, but we wanted everyone to be aware in our broader community about what this study is about and hopefully some of the impacts that it will have. So COM, as you heard, is an acronym, but it really, this study is about multimorbidity. And for anyone who works in children's mental health, child and youth mental health, or who has done work in this domain, you'll know that this is the rule rather than the exception. So we know that youth between 11 and 24 on average have 3.5 mental health diagnoses at one time. This can lead to mental, physical, and social challenges, and really few treatments address multiple conditions, which means that sometimes the effectiveness of these treatments isn't as good. And as a scientist myself, often we design studies that aren't pragmatic in nature. We have long lists of exclusion criteria. We don't include individuals who have multiple conditions because that's messy. But in reality, this is how kids present to the hospital. This is how they present in community. And so I think this study is really an attempt to understand that. We also know that 75% of all adult mental illness begins before age 18. And so trying to understand these factors in childhood and as children become adolescents is really important because we see indicators of mental health conditions early on. And oftentimes the first instances of these mental health challenges occur early. And unfortunately in Canada, this is a really common concern. The Canadian Health Survey on Children and Youth, their 2023 data just came out this week, and it doesn't look good. Kids in Canada, with regards to their mental health, are struggling. Many kids are reporting a worsening in their mental health. And so I think this is, it's a focus at CHEO and it's a focus at the RI and something we want to be paying attention to. So we're delighted to be part of this larger initiative. What we know is that, as I mentioned previously, the age of onset of common mental health disorders happens early. This is a figure from a study, a big meta-analysis done by Marco Solmi, showing the ages of onset of different mental health disorders. So we see the dotted lines actually represent the most likely age of onset. And so all of these, especially anxiety, OCD, eating disorders, mood disorders, substance use, we see happening before the age of 18. And so it's really important to be able to understand how these mental health challenges develop, and also how they might be related to each other so that we can design effective treatments. The COM study that we'll describe shortly the lead sites are SickKids and CAMH. And for the last few years, CAMH has been conducting a longitudinal study called the Toronto Adolescent and Youth Cohort. And they've been recruiting youth and following them longitudinally over time to look at the development and onset of different mental health conditions with a particular interest in who will go on to develop psychosis. And what they found in that cohort that aims to recruit 3,000 individuals and follow them longitudinally is that the median number of mental health diagnoses in youth is 3.5, that 44% of the youth in that cohort were endorsing clinical thresholds of suicidal ideation, and that 49% exceeded the threshold for psychosis spectrum symptoms. So we're really seeing these are youth who are presenting for mental health services. We are seeing a complexity of needs and multiple needs. And we really care about this because all of those conditions and the multitude of conditions are associated with functional impairments. So we know that experiencing mental health difficulties in adolescence is associated with poor quality of life. These youth often struggle in school, will have challenges with relationships with their parents and peers, potentially increased trouble with the law and police, and as well as physical illness down the road. So the ultimate goal of the COM study is to understand mental health in children and youth and figure out how to identify mental health conditions earlier. We're also interested in understanding who is more likely to develop multiple mental health conditions so that we can better understand how to help individuals who are experiencing these conditions. The main objectives of the study are to establish a master observational trial. So this means that individuals will be recruited into the study and they will be followed over time. And they're followed over time in their regular daily lives through the treatment and services that they may be offering. So this is observational in nature to see how do things develop and how do things change over time between those critical years of 11 and 24 years. As part of this study, Anna Marie will describe really the intensive measurement that will happen to identify risk and protective factors for multiple mental health conditions. A main goal is to create a platform and infrastructure for clinical trials. So the larger study is a master observational trial, meaning that individuals are being followed over time, but participants will be offered the opportunity to take part in clinical trials of different transdiagnostic interventions that we'll describe for you. And I think this is really exciting because this means that not only are families being invited to be part of this study and for us to learn from them, but there's also unique opportunities for intervention. And these different trials, there'll be different trials that are happening across the various sites. And the ones that are going to happen at CHEO are still in development. And so part of this talk also is to hear a bit about what you're excited about, what you think would be important. And we'll share a bit about some of the ideas that we have. Through this study, we'll be linking the data that's collected observationally with administrative data and health records and test novel interventions. And then there are also a youth advisory as well as advisory of caregivers and clinicians to really have multiple people involved to help us understand the results from this study and also to disseminate them. So this slide gives you an overview of the COM network. And so across the 6 sites that Gary mentioned, 3,200 children and youth will be recruited into the study. Here at CHEO, we will be collecting data on 560 children and youth over 5 years. So we're contributing almost 20% of the participants to the COM network. The other sites that are joining us are CAMH and SickKids, who are the leads, Alberta Children's Hospital, the Royal, and McMaster Children's. These are the principal investigators across the various sites. And at the top, the lead investigator, Dr. Louise Gallagher, who is at SickKids and who is really steering this study and the lead. But as you can see, I think on our PI calls and our general calls that happen weekly, there are often more than 35 individuals because there are so many team members that are contributing to this study, because as you can imagine, it's an ambitious feat. And when you hear about the measurement, you'll understand even more about why it's so important that we have many people collaborating on this together. And the entire study is funded by a large investment from the Ontario Brain Institute. So now what I'll do is I'll pass it over to Anna Marie, who's going to talk about who's eligible for the COM study and some of the methods.
Thank you, Nicole. So yes, who is eligible for COM? We are looking to recruit youth that are between the ages of 11 to 24 years old, and those that are currently seeking or accessing mental health care at CHEO, as well as those that are able to read and understand in English. When I discuss the DEEP protocol, there is a portion where we will screen for MRI eligibility, but for the most part, this is kind of our broad criteria. So we're looking for youth that are 11 to 24 years of age. So we'll get to the next slide, Nicole. So there are two arms of the COM study at the moment. The first being the master observational trial, which we also term the light phenotype. And here we're really trying to investigate mental health conditions at critical developmental periods in youth to identify risk and protective factors to understand how these develop over time. And within CHEO, our recruitment targets are 240 participants over the next 3 years or 2 years. And as Nicole mentioned earlier, 560 over the full 5 years, of course, pending funding. And within the DEEP phenotype protocol, it's really an extension of the light it's adding additional measures that are not collected within the light. And these measures are such as neuroimaging, clinical, functional, social measures. And this data is collected at only 2 time points, those being at baseline and 6 months. And our recruitment targets for this protocol are 120 participants over the first 3 years and 300 over the full 5 years. Next slide, please. So we're going to recruit for COM kind of through a range of avenues. We're going to tap into our wait list, looking for clinician referrals. So we'd like to engage our wonderful clinician and providers at CHEO, self-referral and EPIC, of course. And if we go to the next slide here, Nicole, really of course, our research team will be providing clinicians with more information. But if you do have a patient that is eligible and interested, you can kind of let us know in a couple of ways, that being documenting it in a note in EPIC, sending an in-basket message to our research coordinator, Karina, or emailing us at com@cheo.on.ca. Next slide, please. And so I briefly mentioned the light phenotype protocol kind of at the outset, but just to get into more interest of what's really happening here. So at baseline, we'll have participants complete these kind of different measures. We're going to collect a wide range of questionnaires for information on demographics, their mental and general health, childhood and developmental history. We're also going to administer a structured interview called the DASH, and this is just to collect more information on their mental health. We will be collecting biological samples like blood and saliva for information on genetics, inflammatory and metabolic markers. And we will also be doing physical assessments to get information on their height, weight, BMI, neck circumference, and blood pressure. And in a couple slides, I will have a graphic that outlines what's really happening at each time point. But within the light protocol, we've got this going on. And in the next slide here, we have some examples of the questionnaires that we will be administering to participants in the light protocol. So Nicole, you could, here we are. So as you see, we've got anxiety, ADHD, bullying, suicidal ideation, and collecting information on medical and developmental history. Now, this is not the exhaustive list, but rather a couple of questionnaires. And I will say questionnaires, not all of them, but some are repeated. And so very briefly, we've got a couple that are repleted at 3 and 6 months following baseline, and then every 6 months after that. Next slide, please. And so this here is our deep phenotype protocol, which I mentioned on the outset before, where we're only collecting information at 2 time points, being baseline and 6 months, and we're really getting additional kind of clinical and cognitive information. So the questionnaires at baseline will focus on general psychopathology, educational attainment, social media use, and physical health. And the questionnaires at 6 months will focus on social and family factors and health services utilization. We will be doing MRI scans only at baseline, and cognitive assessment at baseline will collect information on cognitive processing, and at 6 months we'll focus on social and emotional processing. Next slide, please. So the objectives of the DEEP protocol really are to just identify biological factors that might put some individuals with mental illness at risk for a more severe or complex illness course. And next slide, we really just kind of want to have a look at brain deviations in comparison to normative models. So I won't spend too much time here, because I will get to the next slide, which has examples of really what we're measuring with the questionnaires and cognitive assessment. And so here we've got, for questionnaires, we're extending to, disordered personality, dysfunctional personality, functional impairments with the HUDAS, parent-child relationships with the conflict behavior questionnaire. And at CHEO, we also do hope to add a couple more questionnaires, which I believe Nicole will speak in a little more detail later. And then the cognitive assessment, we're really leveraging the NIH toolbox for a couple of those tests. And next slide.
I was just going to say, Anna Marie, I think one of the important things about the protocol for CALM is that we're also mapping on a lot of the measurement to some larger cohort studies, like the ABCD cohort in the US, that will allow us to do comparisons with population level studies. And so some of the selection of measurements has also been informed by that. And the same thing goes for some of the MRI scans.
Thank you. Yes, so this here is just an overview of the LIGHT protocol. And so you can see at each time point, we've got participants doing different activities. And if we go to the next slide, I'll be able to map on the LIGHT and DEEP protocol, which it really brings it together. I will note that participants can choose to participate in the LIGHT protocol alone, or both the LIGHT and DEEP protocol. But everybody in the DEEP protocol will participate in the LIGHT. And so the DEEP protocol elements are bolded. And so for example, at baseline, we see here that the MRI and cognitive assessment are attached with the LIGHT and DEEP protocol. And participants will be taking part in the study over 3.5 years. And now I will hand it back to Nicole to discuss our caregiver participants.
Great. Thanks, Anna Marie. Yeah, so I think what people can see here from this slide is that there's quite intensive measurement at baseline, and then we'll be looking to follow up with the questionnaires. So at 3, 6 months, 12 months, 18 months, 2 years, and onwards up until 5 years. And so for anyone who's done longitudinal work or longitudinal studies, this is where the heavy work is in following up, keeping people engaged, and being able to obtain this longitudinal data. Another really interesting part about the study is, as we know, children and youth don't grow up in a vacuum. They're part of a broader context, and they have parents and caregivers who are involved in their life, and actually often play a really important role and have a significant influence on their well-being and outcomes. And so currently, the caregivers are completing questionnaires about their child's mental health at the various time points. But one of the things that we're really interested in at CHEO is actually administering some more questionnaires, or for there to be an option to better understand what's happening at the level of the family and what's happening with caregivers. And so what we'll talk about when we show our timelines is that currently REB approval has gone through at a higher level for clinical trials Ontario, and then REB is being subsequently approved at each of the sites. And what we'll be able to do is to modify the study in any way to ask questions that we're really interested in, especially from the point of view of caregivers. And so this is something that we're considering, and something that we think would really elevate the study, elevate the measurement that we have at CHEO, and ultimately elevate our understanding of the children and families who are presenting here with mental health challenges. We had mentioned earlier that there will be opportunity for clinical trials that will occur within the network. And so currently, there are 3 trials that are proposed and will be up and running. The first is a sleep trial, which is a feasibility RCT for treating insomnia and delayed sleep onset in youth between 13 and 18 years of age. That trial is happening at CAMH. There is a self-stigma reduction RCT that is also happening at CAMH. And then a third trial that is called Skywell, which is an RCT that is helping youth and their families to navigate services, especially those who are presenting with really severe mental health. And so all 3 of those trials are having their kickstart or startup at CAMH. There's the possibility and potential that those trials will be offered at other sites. So this has been a really interesting part of the COM network, is to see what trials and what innovations may come from participation. In terms of clinical trials at CHEO, an interest that our group has is around reduction of social media use and promotion of healthier alternative activities for youth and their families. Certainly, we know from some of Gary's work that both about the harmful impacts of social media and excessive screen use in children and adolescents, but also the potential benefits that limiting social media can have for mental health of children and youth. And when we think about the replacement hypothesis, which is it's really about what that excessive screen use is replacing, things like physical activity, social interaction, engaging with peers, and being part of other activities. What we're interested in doing is potentially mounting a trial that would target this specifically. And there are also many strengths in this regard with the HALO team at CHEO, as well as in social prescription in the work that Dr. Sue Bennett is doing. And so we're hoping to leverage some of this as part of the design of a RCT at CHEO. In terms of goals beyond the COM network, we are really hoping to engage with youth and families at CHEO through the patient and family advisory groups and committees. We're interested in building collaboration among researchers and clinicians in mental health. So there are already many other collaborators, Dr. Olivia McLeod, Dr. Nancy Young, many collaborators who are involved in this work and who are consulting and who will also help to lead. We are very interested in the work from COM to have it align with our PCYMH initiatives that are happening at CHEO, and certainly in terms of the intensive measurement that we have, understanding that over time we think that some of the findings from this study will be able to inform personalized approaches to mental health for children and youth. All of the data will contribute to building a large database of intensive biological, psychosocial, and physiological measurement, which will really be one of a kind, especially in Canada, and will give us a very good idea of what is happening for children and youth with multiple mental health conditions and who those children and youth are. And because it's an observational study, we'll also have a very good sense of what services those children and families receive and how their mental health and well-being changes and shifts over time. And ultimately, what we really hope is that the findings from the study have meaningful impact for the care of youth and families who present at CHEO with mental health conditions. Another component that we're really interested in understanding is how early adversity and mental illness in youth are connected. And we know that exposure to early adversity gets under the skin and has implications for health and mental health across the life course. This is information that we're collecting as part of CALM. This is within the LIGHT protocol. We have children and youth reporting on various adverse childhood experiences that they've had. And so this is not core to the main questions of the study, but as you can imagine, there are many questions that will be answered and many opportunities for us to have a deeper understanding. I think lastly, what we're really hoping to highlight at CHEO and bring that is perhaps unique is a focus on resilience. So we have measurements of social support, understanding the peer relationships of children and youth, getting an understanding of parent-child relationships, cultural values, sleep, physical activity, participation in sports. Because it's one thing for us to focus on many of the challenges that arise in families who are seeking mental health care support. But equally important is for us to focus on what are the things that are working, what are the things that help them to be well. And all of that information can inform what interventions and what approaches are being used to support their well-being. There are many strategies for engaging children and youth. And as I mentioned, there is a Youth and Family Advisory Committee that's specific to CALM, and we'll be working closely with the Patient and Family Advisory Committee at CHEO. And the Youth and Family Advisory Committee for CALM has already been very busy consulting with our team and helping us to disseminate a little bit and raise awareness for the study. And one of the things that I thought was really fantastic is at the outset, the youth said, like, what is multimorbidity? We've never heard of this term. We certainly wouldn't use that term to describe ourselves. And so that's a great example of clinicians and researchers, using language and using a term that perhaps in the public sphere, the public domain is not used. And so some of the first work they did was really around debunking what is mental health multimorbidity. And we actually, from there, switched the term to be multiple mental health conditions and to talk about that because that terminology made a lot more sense to youth and it was more user-friendly. And so they have made some really great dissemination tools. I think they'll be making videos and various things. I think it's calmstudy.ca is the website, and so people can go on there and check it out. But the Youth Advisory Committee has been very engaged, and I think that has actually been one of the most amazing and rewarding parts of this work is getting to see the youth in action. And now I'll pass things back to Anna Marie.
Thanks, Nicole. So one of the questions we have today is we'd like to, because we are going to be recruiting from patients at CHEO, we want to share that data back with their providers or clinicians, so long, of course, as they consent to us sharing that data back. And we're interested in potentially providing somewhat of a clinical summary. So, for example, after each time point, the measures that they have completed, we would share that back. And this might look like a report of the DASH results, potentially sharing, their percentile scores relative to norms or scores in relation to clinical cutoffs. But as we're kind of fleshing this out, we wanted to engage, you providers and clinicians to really understand what data might be meaningful for you and how we can make that data accessible for you. So we would really, if you can take a moment to think about that, or even at any time, whether it's now or if you want to email us and just let us know what could be meaningful for you, that would help us get this sorted.
One of the things I'll mention that they've noticed in the TAE study at CAMH that has similar measurement to the COM study is that actually youth who are engaged in TAE receive better care at CAMH, and they actually are more engaged in their treatment, in part because they're interfacing more often with the researchers, and then that information is actually getting fed back to their clinicians. And so that's been an interesting observation from their study, and I think also speaks to the fact that some of the data that's being collected in this study can be shared with clinicians and then can subsequently inform clinical care. So we'll open this up for discussion at the end. In terms of implications, overall, we are hoping to gain an increased understanding of risk and protective factors associated with multimorbidity, to gain knowledge on biological and physical markers of multiple mental health conditions, to identify treatment targets, and to increase collaboration and awareness of youth mental health in partnership with youth and their caregivers. In terms of the launch timeline, so we are currently still waiting, right, Anna Marie?
Yep, still waiting for provincial approval.
So still waiting for provincial approval, after which we will receive approval at CHEO. And then we believe end of September, beginning of October is when we'll launch the study and begin recruitment of our first participants. And through the latter part of the fall, October and November is when we'll be scheduling the first visits. This is our CHEO COM team, Gary and I, who are site leads. And then we have our research coordinator, Karina Brangi, who is on the call today, a research assistant, Dalufa Jaron, and then Anna Marie, who's co-presenting with me today. So with that, well, thank you for your listening. And what we'd like to do is open it up for questions, open it up for comments and suggestions. And certainly if you're interested in checking out more information about the COM study, you can do so at comstudy.ca. Or you're also welcome to contact Gary or myself, or Karina, our research coordinator for the study.
Thanks so much, Nicole and Anna Marie. This is a little bit more unusual for us to present a study before it's about to launch, but given the breadth and impact of this study, really wanted to take the opportunity to present it broadly to this audience. At one point, there were over 70 people on this call. And as you highlighted, we want to be able to recruit patients into this really important study that I think is going to be groundbreaking and really life-altering for many of our patients suffering from mental health. The focus across the lifespan, I think, is really important and really fits with our priority and emphasis on precision child and youth mental health, looking at so many different variables in these patients. Maybe as I wait for people to ask questions and comments, because I know you mentioned a number of people that are engaged and will be engaged with this study, and I see many of them are on the call. As people are thinking of their questions, maybe I'll ask the first question. It was interesting your comment around patients that were involved in clinical trials, in mental health clinical trials, and evidence suggesting that they were receiving, I don't know, better care or maybe more comprehensive care. We see that in oncology as well, where many patients are enrolled on clinical trials, and I think that's helped in some ways create a bit of a culture in oncology around an expectation amongst patients and families, but also amongst frontline staff around clinical trial enrollment. And so my question is, does that culture exist in the broader mental health community? Is that something that we think CALM is going to help create and ultimately not only provide lots of data, but also set the stage for future studies and a future culture of clinical trials to continue to improve child and youth mental health?
Yeah, and I think that's a great observation and question, Jason. And this study is a first of its kind, certainly for mental health. And within the programs at CHEO, the mental health programs, the excellent care is being provided and measurement-based care. And, people are collecting information about their patients and then making evidence-based decisions on that. I think what you've highlighted is this is a large infrastructure that allows us to collect that and to record it all in one place and then be able to use it and feed it back. And so I think that's the opportunity that this provides, and how we go about doing that and how it gets implemented really involves collaboration with clinicians and individuals who are doing the work. And, of course, we have a great plan of how this is going to go. And then there's room within each site for there to be adaptations, shifts, and changes that work well based on the sites and based on feedback that we're getting from clinicians. And so the goal of doing this presentation is really to foster that engagement. And we've had several meetings already with clinicians across mental health spheres, just to really engage people and for people to know that this isn't just a study that's happening on the periphery, but something that we'd like to be embedded at CHEO and to be useful for how we move forward.
Thanks so much, Nicole. Questions or comments?
Hi, Roger.
Hi, congratulations on such a thorough and comprehensive evaluation. I was curious if you are, as part of your data set that you're collecting, I know there's opportunities to link to other data sets like, administrative health data, et cetera. Years ago, I published a study working on visits to the emergency department, looking at air pollutants, actually, and given the importance of air pollution and consequences with climate change, et cetera, going forward, we did find that air pollution was actually associated with mental health increases, surprisingly enough. So I was curious if that's something that your team's going to be embedding and adding that into your models for any future research, and just if that was something that your team had considered or planning to do.
Yeah, I think that's thanks for that suggestion, Roger, and especially given what we know and understand around climate change, very important. And I think what this study demonstrates is that the opportunities for collaboration are endless. And so I think, and that's what we're hoping. And in all the steps that we're taking around data collection and where our data is stored and what's being collected and how we're going to have access to it. Over time, there's very thoughtful decisions being made around that, because I think as you're pointing to, there's real opportunity to answer a variety of questions. And so air pollutants has not been highlighted as necessarily a central research question or a question that has been of interest at the larger group level. But as you're pointing out, there would be an opportunity to answer questions related to that, and to link to administrative data about that.
Thanks, Roger, for your question, and Nicole for your answer. And now to Toby.
Hi, thanks so much for this amazing presentation and much needed work. It's really exciting, and in particular, the multi-center piece is going to be amazing to see when all the data comes together. I think it can have a really big impact. My question was around something you mentioned at the outset. You commented on English language proficiency as being, I thought you said, an inclusion criteria. And so then how are you going to ensure we meet our inclusivity targets? Because we know that those with language and literacy barriers are overrepresented in the racialized population. We've also got our commitment to our Indigenous patients, our commitments to our Francophone patients, and then I would also say some of our differently abled patients also have mental health needs and may need a differential communication approach. And you wouldn't want to, in such a large study, you wouldn't want to cut out such a large group of folks. So what's the thought on how to ensure that those patients are also being recruited and included in the study?
Yeah, and I think that's such an important consideration. And so the English language requirement, some of it is around some of the questionnaires, as well as like the DASH interview itself, primarily being conducted in English. And this is certainly, it's something I think we could bring to the larger group to discuss about how we want to move forward with it, or how we want to move forward at CHEO. I don't think that there has been a plan or been budgeting for, say, like interpreter use or translation. Anna Marie, I don't know if you want to comment on that further.
Yes, I was gonna, yeah, you're correct. Conversations haven't happened, but we can bring this to the larger group for sure.
Thanks for your question, Toby.
Thanks, Toby. Thanks, Nicole. Any other questions or comments for Nicole or Anna Marie? Just give people a moment to see. Stephanie.
Hi, sorry, a bit slow off the mark this morning. Thank you, Nicole and Anna Marie and Gary, for presenting this amazing study. Certainly have had some opportunity to talk with you about it in a bit more detail. Reflecting on a couple of things, thinking about, I was happy to hear about the fact that we'll be measuring service utilization data. We know that's super important, and excited about the opportunity to be able to perhaps use this wealth of data to help predict, right, users of acute mental health services versus, outpatient. Certainly close to my heart, working in inpatient mental health. Curious though about, how, I guess I maybe it's more of a comment or a thought, reflecting on the fact that these services look different at these different sites. And so have you thought about how to, be comparing apples to apples when it comes to the kinds of mental health services that these children and youth will be receiving? We know that, just within the inpatient world, not all inpatient units are the same in terms of their focus, in terms of the kinds of youth that they serve, certainly even between CHEO and the Royal, right? We have different mandates. So just curious about your comments on that.
Yeah, and that's a good observation, and I think points to really the pragmatic nature of this study, and that I don't know from the outset necessarily what our our analyses will look like, as you said, when we're comparing apples to oranges. But I think what it will allow us to do is describe the services that individuals are getting, And in situations, say, within CHEO, where perhaps we're seeing similar trajectories, to be able to understand those a little bit, to describe those, and to see how changes are happening. And then perhaps there are different things that are happening at different sites, and we'll be able to understand those a little bit better and learn from each other. And so, you know, for those of us who do a lot of community-based work, like, this is the messiness of it, but it's also the reality, because it's incredibly challenging to conduct studies that aren't observational in nature, and say, you know, you can't tell people not to be accessing services who truly need them, or for people to wait when they really need services. And so what we will understand is what happens in typical care, and then with the added layer of the trials is how can we elevate what's happening in typical care, and what kind of services can people receive that will help them where they're at, and in improving their mental health outcomes.
Thanks, Stephanie. Thanks, Nicole. And over to Nancy.
Hi there. I don't think I can turn my video on. It says the host has still suppressed it. So I'm going to do this without video until I figure that out, guys. But this is an amazing, somebody released me.
I did. I was like, give Nancy her video powers.
To Nicole. This is an amazing study, and I'm happy to be playing a sort of small supportive role with Nicole and Gary. The group on this call we really need input from this group for a couple of reasons, but one of them is this conversation about what information is useful to the clinician. What is it that we need to get to you? When do we need to get it to you? In what form do we need to get it to you? Is there a component or a visual that we need to provide you to help your conversation with that child? Those are all pieces that we haven't figured out yet, that we need to figure out. But as I think about what PCYMH is doing at CHEO, a lot of that is also thinking about how do we bring research into clinical practice? How do we engage kids with science in a positive experience? So all the clinicians on the call, I'm really asking you to do some deep thinking about how would you like that information? What examples have you seen in other places of dashboards and various other things? I don't know that we want to integrate this all into Epic because I know how painful that is. But we also don't want to create multiple different systems. So I'd love for the clinicians on this call to be selfish and say, what do I need if I'm going to improve my practice with kids and youth? So I'd like to put that call out really clearly. And it was in the presentation, so I just want to come back and re-emphasize that it's super important. And the other opportunity is around the opportunity to think about what the clinical trials are that get added on at CHEO. And the piece that you really need to think about is when we have a sample in a clinical trial, that sample's always biased. We know that there's bias in who enrolls in clinical trials. This gives you the opportunity to enroll youth who've come through an observational trial and to compare to the youth from the observational trial who did not elect to join your clinical trial. So you can look at all the people from the observational trial, all the youth who you could recruit, then you get the ones that you actually recruit for the clinical trial. And now you can compare to those that you didn't include, and that's a rare opportunity. So I'd like people to really think about how we can leverage this trial for other trials that have meaning at CHEO.
Thanks so much for that, Nancy. Nicole, I didn't know if you wanted to respond or add to that.
Oh, I think that's perfect. I think that's why we have people like Nancy, other clinicians also who are part of the project, and we're excited to hear from everybody because, as we said, this is important. This is a CHEO study.
And so, picking up on Nancy's point, this really is a call to action, this Grand Rounds. I think we tend to think of Grand Rounds as being a bit passive. We have information coming to us, which is great, but this is a call to action. Anna Marie, maybe I can ask if you can put in the chat the contact information again, the email addresses, so that people have that. Even if they don't have something now, they can bookmark it or save it so that they know where to go with that information and can think about your and Nicole and Nancy's questions around engagement and what information you want. Because again, this is a bit unusual. We're presenting this at the outset of the study. And so we really want to, while this is a national study, while it is being led by SickKids and CAMH, it really is, we want to CHEO-tize our part of the study and ask the questions that are most relevant to the patients and families we see, and really envelop that in a PCYMH kind of embrace. So I don't see any other questions. I think this has been really engaging. The evaluation has been put in the chat, and a reminder that next week we go to a hybrid format for Grand Round. So there will be in person. This is the first time we've gone back to in person since the pandemic. So there will be in person, and that's in the W1308 room, which is in the on the ground floor of the Max Keeping Wing. So please come and attend in person. And again, Anna Marie has put the email and Nicole and Gary's emails in there. So please don't hesitate to reach out to any of those individuals as you think more about this, or if you want more information on COM. Again, take a moment today to reflect on September 11th, a really meaningful day. Hard to believe we're coming up soon on the 25th anniversary, and really it was a day that changed the world. And again, I think we're still dealing with many of the political fallout from that, but also lots of the mental health fallout. So very, very relevant talk today. And with that, everyone have a good day. Take care.